Good afternoon. Magandang hapon sa inyong lahat. Thank you for joining this webinar. My name is Richie Hara Lazaro. I am a pathologist in the non-commercial division of Medical and Scientific Affairs of Roche Diagnostics Asia Pacific based in Singapore. I will be the moderator in this webinar. Before we start, allow me to point out that should you have any questions during the lecture, kindly raise them by clicking the Q&A icon at the bottom of the screen. We will address your questions after the presentation. Now, allow me to introduce our speaker. Professor Tar Choon is Director of Chemical Pathology at the Department of Laboratory Medicine at Changi General Hospital and Clinical Professor of Pathology at Duke NUS Medical School and Senior Lecturer at NUS, where he was formerly the Vice Dean. He specialized in internal medicine at NUS and the Royal College of Physicians UK, and is certified in chemical pathology by the Royal College of Pathologists of Australasia. He completed internal medicine at Singapore General Hospital and King's College Hospital and Medical School at London, UK. His previous experiences in lab medicine include the Hospital of University of Pennsylvania, USA, a master's degree in public policy from the NUS, now known as Lee Kuan Yew School of Public Policy, and being professor at Monash University Medical School in Malaysia and Australia. He has published widely, including on COVID topics, and is a widely sought lecturer worldwide. We are very privileged to have Prof. Au speak to us about understanding COVID-19 testing and optimizing testing strategies. Professor Au, you may now present.
We thank you for joining us for this session, and I want to thank the Philippine Society of Clinical Microbiology and Infectious Diseases, as well as Roche for arranging this session to understand more about COVID-19 testing. This is what I'm going to do today. I will re-emphasize again that the understanding of testing hinges on our appreciation of the kinetics of the SARS-CoV-2 virus. Then I will unpack for you the viral tests, both the PCR and the antigen, as well as the antibody tests, and I will also talk about some testing strategies. First is that when we are exposed to the virus begins to grow inside us and the viral load increases and it peaks before it declines. There is an incubation period between the exposure to the onset of symptoms, and this incubation period is usually said to be 4 to 6 days, but it can be 2 to 14 days or even longer. Viral load peaks prior to the onset of symptoms, and the infectiousness or transmissibility of the virus is 1 to 2 days before symptoms arise and 1 week thereafter. But there are also others who are pre-symptomatic or asymptomatic who are also contagious. In fact, one study in the Belgium long-term care facility, 80% of the residents of the long-term care facility and the staff have the infection but are asymptomatic. At this point, you'll find that the number of FDA-approved tests and kits is a lot. And there's 189 molecular, 7 antigen, as well as 57 serology and other lab-developed tests as well. To understand the tests are of two sorts. The viral tests, either we detect the RNA or the antigen, and the serology tests. And these tests may either be central lab or rapid tests. The PCR test is measuring the RNA from the virus, and it detects current infections. There's a great disdain for this test because the collection of the sample from the nasopharyngeal swab is often described as a brain biopsy. And there are problems that we knew from before, that the nasopharyngeal swab, the flock swab, is better than the rayon swab. Because of this, alternative samples such as saliva is gaining some traction. However, it's not so straightforward. While it is non-invasive and easily collected, the use of PPE may be as the same, although greater patient acceptance and potential for home collection makes it attractive. The variation in saliva varies, and the time taken to collect may be more than the nasopharyngeal swab, and the patients must not be eating, smoking, or drinking for 30 minutes before collection. The FDA has provided some guidance if we want to use alternative specimens. We have to have paired samples, 30 positive and 30 negative, over a wide range of viral burdens, and the comparator should be of a high sensitivity test, and there should be a 95% positive and negative agreement with similar CT values. Early on in Singapore, this has just been published, the gray bars is the yield from saliva. It's much lower than the nasopharyngeal swab in dots. And for those who are contemplating embarking on saliva testing, I would refer you to this CAP Today article, where it is actually quite challenging to optimize the saliva. That's why many people don't quite like the saliva, although it is attractive to other bystanders. A word or two on the pool testing. Pool testing has been used really mainly to conserve supplies, right, and also increase the testing capacity. So if you have 100 and only one is positive, then you only need to do 10 tests. And then from that 10, then you do individuals another 10. So you save 80%. It is good for high throughput testing where the disease prevalence is less than 5%. If the prevalence is more than 5%, then there's more work than is needed. And the suggestion is that the pool should be no more than 5 and with 2 rounds of testing. Next, we come to PCR gene targets. Different assays have got different gene targets, and even within the gene targets, there are slight variations. So that makes for complexity when we try and compare different methods. And you can see in this slide that the different agencies of the different countries use different targets, from 1 gene, 3 genes, 2 gene targets, right? And to make things more complicated, even the probes, even with the same gene target, could be different, and the primers could also be different. At the same time, the processing of the PCR could be manual and involves many steps. So there's great potential for errors to occur along the way, and the precision is unlikely to be great when you have got so many steps. So there are labs which have started with manual testing, like the Thermo Fisher TaqPath, right, to a slightly more automated. It's a 4-hour batch mode, to a Hologic 8-hour batch mode, to another higher throughput 8-hour batch mode, to now a 2-hour random access, right? Roche also has the random access systems, right, that can do about 1,150 tests per 24 hours or over 3,000 tests per 24 hours. But remember, these instruments are huge and weigh more than a car. So you have to ensure that the floor in the test lab is sufficiently strengthened. Other issue with PCR is that the limit of detection and the units are variously expressed. Copies per mil, copies per microliter, copy equivalents per reaction, genomic RNA copies per mil, genome copies per mil, NDU per mil, and TCID 50 per mil. So the FDA came up with a panel to be distributed to manufacturers as well as labs that want to compare the sensitivities. But it's a relative sensitivity, and it's reported as NDUs per mil. But even within this FDA panel, we have tests which range from 180 to 540,000 NDUs per mil, a 3,000-fold difference. And then we also have the limit of detection expressed per reaction. And you find that the per reaction, depending on whether the reaction volume is 25 microliters or 50 microliters, you need to multiply it by 20 to 40 to get copies per mil. And then the LOD is also expressed by TCID 50 per mil. And roughly it's equal to about 3,555 copies per mil. So you have to multiply that. So the Roche assay of 0.009 TCID 50 is equivalent to 32 copies per mil. Now, even the LOD expressed in copies per mil, you have different ranges of approved methods that vary from 40 copies per mil to 100,000 copies per mil. So even for RT-PCR, they are all not equal. And you have to look at the instructions for use and the literature to compare, right? Here are 6 approved RT-PCR. When they diluted it down to about 240 copies per mil, you find that, only 4 of them, or 3 of them are able to detect to that level. Again, the sensitivity in LOD matters because, say, the Abbott M2000 are capable of detecting down to 200 copies per mil, right, will of course have the most number of cases detected, whereas a less sensitive assay like the LabCorp EUA 6250 copies per mil would be able to detect less samples. Another issue is the viral load and the cycle threshold, right? In the instrument, right, as soon as the fluorescence signal exceeds a threshold, it lights up. So here, the lower the number is the higher the viral load. So if it lights up after 20 cycles, this is reported as 20. And if it lights up after 29 cycles, it is 29. So it requires more cycles to amplify the signal. The CT value is, the viral load is proportional to also the number of copies, right? So the higher the CT number, right, the lower the copies. So the lower the number, the higher the viral load. Again, the viral load is also predictive of outcomes. So the lower the viral load, right, the greater is the number of deaths and patients who are intubated. So the viral load also declines with time, right? And there's slight differences between the different gene targets. For the N gene, right, there's this thing called the 35-10 window. So at the CT value of 35, all right, it's 10 days where it begins to go up. And for RDRP gene, it's about 35 and 11.5. And for the E gene, it's about 35 and 12. Right. In this other publication, they showed that in their hands, when the CT value is 30 and after 15 days, they could not culture any live virus. And more publications now have shown that there's no detectable culturable live virus after 10 days from symptom onset. And another interesting publication that came out is talking about the College of American Pathologists external QA survey. You find that the same sample done by different labs with different instruments, the Abbott M2000, right, records a much lower CT value compared to the others, right? Even the others, you find that there is a wide spread of CT values even on the same platform, which may differ by as much as 6 cycles, so which is quite a lot. So more needs to be done by way of standardization and harmonization. So should we then be reporting the cycle thresholds for molecular testing? I'm not sure that the doctors and even lab personnel are ready for this sort of thing, because it's not quite so easy to explain it away, other than to say that, look, if we compare 2 different cycle threshold values at different time points of the illness, we might get an idea of the clearance of the virus. There's also a possibility for the PCR to be positive in the non-infectious period, particularly the pre-infection period, as well as the post-infection period. Here, it's not so critical, but here, right, you could have some significance if a less sensitive test is used, because you're going to miss this early rise. And so it's only the red zone that matters clinically, but this window is actually very short, and the viral growth is exponential and will happen over the next 12 to 36 hours. There's also the possibility for false positive test results, and we have to make sure that we minimize for it. And there's a great review paper here that I've referenced here for your benefit. So we should test for it. We should apply caution, especially when the results are close to the limit of detection of the assay. Right? We must be careful in our lab practice to make sure that we are quite sterile and careful, and we dispose of all materials very carefully as well. There's also false negatives with PCR, and you find that on the day of symptoms, right, the false negative rate may be as high as 38%, and by the 7th day, it will be 20%. But thereafter, the false negative rate increases. Labs see high false negative rates, right, and up to 12% of labs may have reported that they encounter false negatives. This is a survey from the American Molecular Pathology Association. There's also rapid molecular tests, such as the Cepheid, which is very good. It's 45 minutes, right? If you have a positive, high positivity, you may get a result in 30 minutes. The LOD is 200 cycles, copies per mil, and it's listed as 5,400 NDU per mil. The Abbott ID now is 15 minutes, and a positive reaction may be obtained in as little as 5 minutes, right? The LOD is 3,000 copies, and the NDU is 300,000, much more than the Sapphire. And then Roche also has a multiplex assay that is now going to be available with influenza A and B. And this one is 1,800 NDU, or about 50 copies per mil. So the overall sensitivity and specificity of the published literature in the Cochrane review shows that the sensitivity is about 95.2% for the rapid molecular test and a specificity of 98.9%. Next, we come to antigen, right? The reason for the attractiveness of the antigen is that antigen is detectable no more than 7 or 9 days after symptom onset. And it avoids the positivity with long tail in the PCR methods. And the proof of the short duration of the antigen, right? Here is the N antigen, right, in red, right? This it has come down by day 5. Here is taking a bit longer, about day 10, 9, 10. And the S antigen is also about day 5. There are about 7 approved antigen tests with varying limits of sensitivity. All are about 15 minutes, all right? And all are recommended for testing within 7 days of symptoms. The Roche assay has a claimed sensitivity of 96.5% and a specificity of 99.7%. The utility, I think, again, we have to, if we confine it to symptomatic patients, it will perform well. The results are available in 15 minutes. The cost is certainly lower than molecular, and it's very useful in areas with limited access to molecular testing. And in situations where we need rapid results, such as the emergency department or urgent pre-operative cases, screening in congregate living settings as dormitories, and then possibly back to work. Again, the Cochrane review, this is published in August, right? So, only has 5 studies, right? The overall sensitivity is about 56.2%, and the specificity is 99.5%. So again, underscoring the fact that the specificity is 99% and up. So if we use antigen tests with a sensitivity of 56.2% and a specificity of 99.5%, if we use it in a low prevalence situation, we're going to run into trouble. The predictive value is only 10%. But if it goes up to 1%, then the PPV goes up to 53%. And if it is more than 5% prevalence, then it's 85%. So the NPV is quite okay. It's better than 95%. So the prevalence where we use the test, all right, and the population will matter and affect the performance. So if we take the Roche antigen test, and if it has the sensitivity of 96.5 and specificity of 99.7, even at 1%, it's 24% PPV, and at 0.5%, it jumps to 60%. So this is clearly going to be much more attractive. So there are unmet needs in antigen testing, all right? Are we sure of the supplies being uninterrupted? And so far, right, it still requires a swab, and the question of whether saliva can be used, right, hasn't surfaced yet. So the choice between the viral test, nucleic acid, or antigen will depend on a variety of factors. Cost is more expensive for the nucleic acid test. Of course, sensitivity is there. Scaling up is easier on the antigen. and the underserved areas. Frequent testing is attractive, ease of use, of course, and the issue, of course, would be supply chain, whether we can guarantee that. And moving on to serology, you find that in serology, the test is measuring the immune response to a current or past infection. Right? It measures exposure to the virus. Nucleocapsid is used by many manufacturers because the abundance of the protein as well as the stronger avidity of this protein. All right. Conventionally, we think in other viruses that the IgM comes out first and then the IgG develops in the second week of infection. But this is not quite the same in the COVID infection. You find that as the virus begins to decline, weeks of symptoms, you find that the G and M actually are tracking quite closely. Secondly, the G, rises much more than the M. And this is the latest meta-analysis of all the serology tests, and the total antibodies will outperform the G and outperform the M. All right, this is our evaluation of the Roche CLIA on the COBAS. And again, the cross-reactivity is outstanding, right? Better than 99%. And the signal to concentration is quite good, and signal to sample concentration is linear up to 90 COI units. And the precision is also quite good, right? It's under 5%, right? And even at the borderline zones, the cutoff is 1, all right, 0.9 and 1.1, all right, it is under 3% CD. The throughput is outstanding. We can do 200 samples in an hour, 300 samples in 76 minutes. The sensitivity is quite interesting. By the first week, right, we are able to detect the antibodies in 48% of the subjects, and of course by week 3, right, 100% will have seropositivity. Right, this is also shown in other evaluations of the Roche assay. Right, first 6 days, 46.7%, right, seropositive, and here 50% by day 3. Right, its use of serology has been helpful in a family cluster. Right, these are subjects. Right, these 3 subjects here had positive IgM. Right, and this the grandfather had also IgG. These 3 were all PCR negative. In the same paper, they also compared PCR alone and PCR plus the IgM ELISA. It showed that the positive detection rate goes up from 52% to close to 99%. So this slide of the various components of the response of the body, right? In this first few weeks, right, the PCR is likely to be positive, right, the blue line, and the hatch lines are where the antibody detection begins. And so there will be a period of overlap from the day 7 onwards to day 21, where both are likely to be positive. So the use of these 2 tests together gives us greater clarity in the results. Again, 2 tests are better than 1. This is data from Boston Mass General Hospital. They have daily serology going up here, and this is daily PCR coming down. Right, so you find that there will be a good period where more than half of the patients will have positivity for both somewhere from day 5 to about day 18. In another study, right, they have shown also in, say, the first week, right, PCR alone is about 67%, right, antibody alone is about 38%, but if you use both, it's about 79%. So if we use two tests, right, in a sequential fashion, right, let's say we use the antibody first and then the PCR. If we use a sensitivity of 50% for the antibody and 99% for the specificity, and we use the PCR sensitivity of 70 and specificity of 99.5%, alone at prevalence of 0.1%, right, the performance is less than 5% and 6.5%. If you use together, all right, in the sequential fashion, the PPV improves to 77.8%. Thus, we are able to reduce the false positive rate. And the moment it hits 1% prevalence, the use of two tests orthogonally, you will get a PPV of 98.6%. That means the false positive rate is less than 2%. So if we use two tests, right, and even if together, right, if the molecular is positive, the antibody is negative, it's early infection, both are positive, it's active infection, both are negative, they are not exposed, and if the molecular is negative and the antibody is positive, then it could have been some remote infection previously. Now come to the Roche antibody assay, the rapid antibody assay. They also have with a claim specificity of close to 99% and sensitivity of 99%. And the new generation of rapid POCT antibody tests all have specificity better than 99%, right? Except for this one here and this publication. Right? In our hands, we find that the specificity and cross-reactivity is outstanding, right? No false positives. And the sensitivity, right, is comparable to the Roche total antibody assay, right? In the first week, it rises to about 78% in the second week and more than 97% after 2 weeks. So in terms of concordance, right, it's, in the first week, it's 78.5 concordant with the total antibody assay on the COBAS and 100% on the other areas. And for the negative controls, it's all 100% agreement. So if we use two tests sequentially in orthogonal fashion, all right, say we take the antigen at the combined overall sensitivity of 56.2 and specificity of 99.5, and say that the sensitivity of the Roche antibody assay is 20% and 97.2, as we found, you find that at 0.1%, the antigen test by itself is also not good. But if you use it sequentially, orthogonally, right, even at 0.1%, right, it goes up to 44%. And 0.2%, you're better than 50%, or you have reduced the false positive by 50%. And if it is at 1% prevalence, right, the false positive rate would have dropped to 11%. And at 5% and above, oh, you're close to better than 98%. So the Roche has also announced the antigen tests to be performed on chemiluminescence immunoassay on the COBAS, and I'm sure the performance will be better than the rapid antigen tests. So we look forward to this assay. What have I told you today? I've re-emphasized the understanding of testing by remembering the kinetics of the SARS-CoV-2 virus and the explored the different tests available, the PCR, the antigen, and the antibody tests, as well as highlighted the utility of tests, right? Uh, Either antibody with PCR or antibody with antigen. Thank you very much.
Can you hear me? Good afternoon, good evening, Philippines.
Good.
Hi, Prof. Au. Thank you very much for a comprehensive and informative lecture. And thank you for gracing this occasion in my country. I'm also from the Philippines. I think I know some of you in the audience, and I would encourage you please to raise your questions in the Q&A icon at the bottom of your screen. So some questions have come in, and we will take care of them one by one. I'll try to compartmentalize them as I go. Prof. Au, this is a frequently asked question, actually. An anonymous attendee says, thank you for the lecture. May I ask which test would you recommend for pediatric patients? And I think it's too generic. Maybe we will say, what about asymptomatic pediatric patients versus symptomatic pediatric patients?
I think for starters, if unless there's a special reason to test the asymptomatic child, right? Most of the time, the testing would be for the symptomatic child. For the symptomatic child, I think today it would be good to use, say, the antigen test rather than the PCR test for starters, simply because the sample collection is a nasal sample, so it will be much, much easier. And if there's any, if they are symptomatic, the likelihood that they already have possible disease is much higher. So, we can just do the antigen test alone, and that will be fine. But if you still think that you need to do another test, then as I had shown that two tests are better than one, we could also do a finger prick on the child for the rapid POCT. If the test is positive, I'm sure for now, the attending pediatrician would like to have the comfort of knowing the PCR status. Then, of course, we can still do that. But at least if we have excluded and both are negative, then we can be quite safe to say that in that situation, better than 90% likely to be, quite fine, and there will be very few false positives.
Thank you, Prof. Au. Speaking of false positives, I'll go on to the next question. What are some factors that might cause false positive or false negative results?
Well, it depends on the test. I've gone through, for PCR, I think the biggest factor really is the sampling, right? The ability to sample it accurately. I mean, that goes true for everything that we do. Even if we did a biopsy for something else, if the sample is not in the right spot, we are going to get a negative result, even though the patient truly has, the disease. So no different with the nasopharyngeal swab. The other problem, though, is that we have no way of knowing where in the disease evolution are we with a particular patient, right? So the viral load peaks, 24, 48 hours before symptoms arise. So by the time the patient comes to us, the viral load is already beginning on the decline slope. So that is the unfortunate thing that we have here. So therefore, those are the possible reasons. And the other thing is that the choice of the platform is vital. All right. If we choose to have a PCR method that only lights up at 100,000 copies and the patient has 90,000 copies, then we are going to report a negative result, right? The other issue, though, is that the industry needs to come together with the regulatory authorities to try and ensure some standardization and harmonization. Right? Results from the first round of the CAP EQA survey is a bit worrying, right? So you have Abbott that is, reporting at 20 plus, and everybody else is at 30 plus, right? 20 plus for most of us is a huge viral load, but you know, so obviously the calibration in the Abbott system is slightly different. But even within the same platform, it is worrying that the range of CT values ranges by up to 6 cycles. So that's huge. So until we can improve that, I think that these are challenges for us. So you can find that the choice of the platform and the standardization, we could also have that. So the false negatives are there. So in that Annals of Internal Medicine paper from John Hopkins, right? On the day of symptoms, the false negative rate is 38%, and by day 8 is 20%, right? Because of this shifting, goalpost of the viral load. So we don't have a choice. That is the case there. Then we also have the uncommonly for PCR is false positives because two factors. One is the fact that if the lab practice is not up to speed, right, there could be contamination. But when the PCR is used in symptomatic patients in the hospital, it's quite okay, right? It'll be quite high in terms of the false positive rate will be quite low. But as I showed you, if we went to the community, all right, at border control, where the prevalence is say 0.1%, any test would by itself would be less than 10%. All right, that means 90% of the time is going to be a false positive. So in those places, in order to reduce the false positive rate, right, I put it to you that if we use two tests, right, sequentially, right, or both together, right, we would be able to reduce the false positive rate to at least only 30% from 90% in a 0.1% prevalence situation. For the antigen test, all right, the manufacturers all say that you have to use it in symptomatic patients. But if we use it in asymptomatic patients and in border control, then buyer beware. And we have to then, take the risk. Again, the same thing, right? I already showed you that if it is in a low prevalence situation, right, you are better off if we use two tests, right? So these are some of the factors. The antibody test, again, is the same, right? All antibody tests, the specificity today is better than 99%. But the sensitivity depends on where in the evolution of the disease is. If we use it day 14 and beyond, it's okay. All of it would be 90+%, reactive. But more than that, we don't know. So if you have got an asymptomatic patient, we really don't know. But if you really want to use antibody, right, in the asymptomatic stage, it would be preferable to use the chemiluminescent immunoassay because we can pick them up, 40-50% of the cases in the first week, whereas the POCT we are only going to be able to pick up 10 to 20%.
Thank you, Prof. Al. So in the Philippines, the ramping up of testing started sometime in March, and it started with PCR as per like the gold standard, and then there was the antibody tests, and many of these antibody tests were these rapid kits which look like the pregnancy sticks. And then now newer tests are coming in. So you have your antigen tests, as you have explained nicely in your lecture. And then there's the saliva method also, which could be either the antigen test and the PCR, correct? Am I correct? And any comment on using the saliva for these viral tests?
Okay. Saliva is more for the PCR, right?
Okay.
I haven't seen the antigen paper on antigen using saliva just yet, right? If
Okay.
Yeah, but the issue with saliva is saliva is a more difficult sample to handle because some saliva specimens are quite viscous. So we need to put in, something a mucolytic to dissolve it, right? Either something like diethyltrietol or something like that. So again, you have to add something. So you have to remember that when you add a solution to try and solubilize the saliva, we are diluting the sample a little bit. So again, unless it's verified, it's going to be difficult. Most of the kids that have done this would say that they are able to do so, say up to a level of CT of somewhere 30 or low 30s. Right. So then again, like I said, it would behoove those who want to embark on the saliva route to read the CAP Today November article, because this was from a person whose bosses and the public wanted the saliva test. And he had to be in the lab, for weeks and nights on end to try and solve it. It's not quite so simple. You have to get the mixture right. Right. So I think, it's important to really consider that. But the attraction remains,
Yeah.
right? It's an easier sample to collect.
Yeah.
It's less resource intensive. All right. So everybody will say, yeah, why don't we use saliva? So I think, yeah, that is the case. But I look forward to saliva also on the antigen strips. Right. I don't see why
Yeah.
it cannot be done. But
Yeah.
like I said, unless we have a validation of that, it would be difficult to know exactly how well it handles.
Thank you. So it's convenient for the patient if it's saliva, but very inconvenient for the lab.
Yes.
So, all right. And the sensitivity is lower than the PCR with the the brain swab that you were saying, right? And
Well, depends. The okay, for PCR, the same instrument, the same platform.
yeah,
There are publications that say it's about equal. There are publications that say the nasopharyngeal swab is better, and a few say that the saliva is better. So I think it depends
okay,
on who is writing the paper.
okay. Got it, got it. There's a question here that wants you to elaborate on the SARS-CoV-2 antigen test. Can it be a basis for COVID-19 diagnosis? And what do you think of its sensitivity? And what are some factors for false positive or false negative?
Well, um, the same issue. Right? Remember the kinetics of the virus, right? Right. So the advantage is that um, after 7 or 8 or 9 days, right, you have no more detectable viral antigen. So the good thing is you are not going to have if the long tail of the PCR on the right hand side of the curve. So that is the great advantage of the antigen. But depending on the antigen uh, test sensitivity, right? That means what is the limit of detection of that particular assay? There's a great difference, all right? Sometimes that number is hard to come by, all right? So they will hide it in by saying to you that it is a TCID 50 per mil, and then you have to try and back calculate to see, all right, if you compare it in terms of the more familiar copies per mil, it is not quite the same. So if you say, okay, I want to use the antigen, then I would suggest, all right, find the antigen test that has the lowest limit of detection so that you are not going to miss so many cases. Then the next thing is, okay, all the antigen tests so far say that they, in their instructions for use, they say that they are referenced to about a cycle threshold of 30, 31, or 32, like that. But as I showed, right, it depends on who's 30 or 31 or 32, right? Because they don't tell you that, right? So these are some of the caveats we have. Again, all of the package inserts say that it is to be used only in symptomatic patients and within the first 7 days. But if we use it in border control and the community, we have no way of knowing. So that is again another problem. So by itself, I think it would be dangerous to say whether the patient is free of disease or with disease. So I think even if it is positive on the antigen test, right, most of us would say, right, what is the PCR reading, right? So they would rather than just on that alone. But we will see. We need more data on that. Yeah.
Understand. Now, I want to ask about antibody testing. What would be the implications of negative antibody tests in a recovered patient? Now, it's quite generic. This is another frequently asked question. You may answer it according to scenarios if you wish.
Okay. In a recovered patient, right? Firstly, the reports that come out, all right, are a bit strange sometimes. Right? If the first is the platform reliable or not that's providing the antibody result? Okay. In my books, right, an ELISA test would be lower than a chemiluminescent immunoassay test in terms of my preference, because the chemiluminescence, autoanalyzer is way better in terms of sensitivity, speed, and advantages there. So if it is ELISA, all right, it is simply because the amount of signal molecules you can pack into the enzyme is less than the chemiluminescent particle. So sensitivity is better for chemiluminescence. And then, is it an in-house assay or is it a robust manufacturer provided assay? All right. So the in-house assay, you don't know how reliable it is, other than whatever they say it is. So be careful about the reading about whether the antibody is detectable, not detectable, wane, or otherwise. If we look at, say, the Roche assay from Iceland, right? They were able to show that after 100 days, the antibodies were still present, right? In our own hands, in some of the patients who have recovered, right? As long as 150 days, they are still present. But presence or absence of the antibodies, all it says is that you have been exposed to the virus. But the real question that most people want to ask is, I have the antibody, does that mean that I'm immune?
Yeah.
The issue of immunity is not quite so clear. All right. There are some early tests to say that, yes, how do we measure the immunity? Well, we use a neutralization assay. The neutralization assay, we only have one neutralization assay that's FDA approved just now, and that is an ELISA. All right. So again, I'm not, quite so, keen on ELISA. But what to do? Right now, it's the only one. So if I want to study it, I have to use that one. All the others are all in-house lab-developed tests. So not sure. Mm-hmm. To circumvent that, manufacturers have come out to say that their auto-analyzer immunoassays correlate with some neutralization assay, especially those that are to the spike protein or the receptor binding domain protein. Even some with the nucleocapsid protein also say that there is an association, right? Maybe 50%, 60%, right? The correlation association is higher with the spike and the RBD. So we have to see, because these are all quite recent sort of papers. We have to say, okay, next year what happens to this space in terms of immunity, neutralization, and whether or not it correlates.
Got it. Prof. Al, we're at the end of our hour. May I ask for a 5-minute extension, because I really want to ask about vaccines, and I think the audience would be curious. In my country, Philippines, the records show there's about 399,000 recovered patients. Uh, and would, as per your saying, that may not mean they're immune. So what would be the preparation for the vaccination? Would recovered patients be included? And then there's a question here from Jose Angbenko. Are the vaccines that will be available safe, and how long will be effective? So just share some thoughts on vaccines, please.
The safety and efficacy of the vaccines, I think we'll have to await that. I mean, because the data is not published, we don't know, right? So whoever is in the regulatory authorities in the DOH reviewing that will be best, to evaluate those things, right? That aside, I'm sure, the DOH will release whatever they feel would be the most beneficial. Again, whichever country it is not going to be so readily available. So there will be some prioritization that will be needed and necessary, I would think, right? So who are your top target groups to receive the vaccines, right? From what I've seen and the discussions ongoing, right? The healthcare workers, for sure.
Yeah.
People who are the highest risk at the at
Most
the
exposed.
nursing homes, right?
Yeah.
And the elderly would be next, right? So these are the two key groups I've heard the case. The people that have recovered, I would think they would be lower on the priority simply because the risk of reinfection is going to be very, very low, right? We have millions of people who have contracted the disease, and the number of cases where reinfection has been established is less than a handful. So unless we have the capacity to do genome sequencing of the different virus from the different patients, it is very hard to say that you have got a reinfection, right? Because it's not clear, right? So I would say those are the priority groups off the top of my head. Yeah.
Thank you, Prof. We've reached the end of our session. Thank you very much for your wonderful lecture and explanation in the question and answer portion. Thank you to those who raised questions. If you have Roche specific questions, and there was one about the Cobas Liat, please reach out to your Roche representative. I would like to thank the audience for participating. I want to thank Roche Philippines for this session, and thank you for the organizers of the Philippine Society of Microbiology Association. Thank you so much, Bismid.
Thank you.
Yeah.
Same. Keep safe, keep healthy, and
likewise,
thank you
Doctor.
again. Bye.
Yeah.